Welcome back to OpenMed School. In the last sessions, we have discussed about the pathogenesis of GBS and triaging and when to admit to ICU. Today, we'll be discussing the part 3 of the GBS specific management, that is the immunotherapy.
Here are matches for manager.
So let us have the recap. We had the 42-year-old man with progressive weakness, bulbar symptoms, forced vital capacity less than 1 liter, autonomic instability, and was admitted to ICU. The triage is complete. Let us plan the specific management. The core therapy of GBS includes two. One is the plasmapheresis, and second is the IV Immunoglobulin. When will you advocate immunotherapy? Immunotherapy with IVIg or plasmapheresis is indicated to non-ambulatory patients within 4 weeks of symptom onset, or in ambulatory patients within 2 weeks who are progressing. Is that point clear to you? That is, in non-ambulatory patients, that is, a patient is bedridden, cannot walk. Such a patient, if the duration is less than 4 weeks, definitely you can start home. And if the patient is ambulatory but is rapidly progressing, that is what is meant by non-ambulatory patients, again, immunotherapy is indicated. So, I stress this, immunotherapy is indicated in patients, non-ambulatory patients within 4 weeks of symptom onset, or ambulatory patients within 2 weeks who are progressing. Progression means think that the patient came walking, next day he is unable to get up from the squatting position. Definitely that is a rapid progression, and you may think about the immunotherapy. So what are the options? The first line options are either IVIg or plasmapheresis. Let us look into little more details on this. What's the dosage of IVIg? Dosage IVIg is 0.4 grams per kilogram per day into 5 days. So that is the point of 0.4 grams per kilogram for 5 days. What is the mechanism? It neutralizes the pathogenic autoantibodies and modulate the immune response. IVIg is effective as plasma exchange, but with the benefit of being easier to administer, especially in unstable patients. So that's a point to be noted. That is, IVIg can be administered in anywhere, even in a peripheral hospital. And plasmapheresis is difficult in an unstable patient hemodynamically, and such cases also IVIg is better. So, can you repeat the IVIg? You can repeat a second course in patients with clinical deterioration or after initial response, though the data is limited. So you can give a second course. But the point to be remembered is don't give IVIg and plasma exchange together. It may interfere. So point to be remembered is plasma exchange and IV immunoglobulin are equally effective, but don't give both together. Now coming to plasma exchange, standard dose is 4 to 6 exchanges or sessions over 7 to 14 days. Within 2 weeks, you give 4 to 6 exchanges. Mechanism, it removes the circulating autoantibodies and complement. So last time we have discussed that the mechanism is complement mediated and also the antibody mediated. The plasma exchange hastens the recovery of GBS and is especially useful if started within 7 days of onset. So this is another point to be. So plasma exchange will be more effective within 7 days of onset of the treatment. So let us look what are the situations where you should avoid plasma exchange. Plasma exchange is avoided in elderly and hemodynamically unstable patients and those with the difficulty to get vascular access. So as mentioned, this important point, that is in unstable patients, plasma exchange will be better. So now the question is, which one to choose? Is it the plasma exchange or IVIg? There is no major difference in the efficacy, but IVIg is preferred in many settings due to greater availability and fewer complications. So many people consider this as the choice, even though both are equally effective. Now we go to the summary. So IVIg can be given through a peripheral vein, but for PLEX, an invasive line is required. The risk of hypertension is low, but PLEX is higher, and so hemodynamically unstable patients you cannot do. Monitoring is very simple here. Here, the in PLEX you require plasma volume balance. Availability often limited in resource poor settings. That's the problem with the gain. And plasma exchange may be cheaper in many settings. That is the advantage of plasma exchange. Now you go to the supportive care. Supportive care is not just add-on treatment. Supportive care is critical in the management of GBS. And it may determine the outcome as much as immunotherapy. As mentioned, respiratory support. Prepare for intubation early, especially when the force vital capacity is less than 15 ml per kilogram or less than 1 liter. Monitor the ABG, oxygen saturation, and carbon dioxide retention. So these are fundamental in managing. Remember, GBS is a motor neuropathy. Sensation is preserved in most cases, and most patients can fully be aware of the things when they are ventilated. So when you are managing the patient, this is something that you keep in mind. So now we go into the second part is the nutrition and swallowing. So first is the hemodynamic and ventilation monitoring. Second is the nutrition. Perform swallowing assessment daily. Nasogastric feed should be given when there is a risk of aspiration. Monitor electrolytes and fluid balance. This is one peripheral neurosystem disease where you can get hyponatremia. And hyponatremia is very common. What is one of the characteristic feature in GBS like presentation in acute intermittent porphyria. In severely weak patients, the risk of aspiration is very high and needs aggressive prevention. Psychological support is essential. Anxiety, depression, especially very common in ventilated patients. Consider about reassurance, communication boards, and psychological support for these patients. A paralyzed patient who cannot speak or move but is fully aware, and these are conditions which are terrifying to the patient. So keep this in mind. So today we have discussed about the psychological problems. One another important thing to remember is the DVT prophylaxis. Patient is immobile and there is high risk of venous thromboembolism. So start low molecular weight heparin whenever there is no contraindication is there. So this is something that you should keep in mind, that is patients with GBS are at high risk of venous thromboembolism and should be on DVT prophylaxis unless there is any contraindication is there. Then pressure sores and joint care, frequent repositioning, physiotherapy, passive limb movements to prevent contractures. So then pain management is something which you often forget. Neuropathic pain is present in many patients and it is often unrecognized and unnoticed. Despite it being treatable. So you may use gabapentin, tramadol in low doses, and if severe symptoms are there, even opioids can be given. So now we go to the summary. So the first line immunotherapy is IVIg, 0.4 grams per kilogram body weight into 5 days or plasma exchange 4 to 6 sessions over 2 weeks period or 7 to 14 days you give 4 to 6 sessions. When to treat? Non-ambulatory patients within 4 weeks, ambulatory patients within 2 weeks if the patient is deteriorating. Avoid combining IVIg and PLEX. Supportive care for ventilation, DVT prophylaxis, pain control, nutrition, and pressure sores are essential. So, we'll revisit our patient. The patient has rapid progression, that is bulbar dysfunction, the forced vital capacity was less than 1 liter. So, admit the patient to ICU, give IVIg, prepare for ventilation. So, don't wait for respiratory arrest. Prepare, start low molecular weight heparin, start for physiotherapy, and have a nutritional assessment and plan for nutrition. Now, we'll give 2 MCQs. First question. A 50-year-old man with GBS presents with forced vital capacity 1.4 liter, difficulty in swallowing, that is bulbar dysfunction, facial hyplegia. What is the most appropriate next step? So this patient has got bulbar symptoms, high risk of going to respiratory paralysis. So the best treatment would be start IVIg. So in ambulatory patients with the duration is less than 2 weeks and progression is there. And in non-ambulatory, that is bedridden patients, within 4 weeks, you can start on treatment. Never give IVIg and PLEX together. Observe and repeat FEC next day. Again, is not the correct option. Never start on corticosteroids. So, correct answer is IVIg. Corticosteroids are not effective. Observation without therapy is inappropriate. PLEX and IVIg should not be combined. Hope these 2 points are clear to you. So GBS is treatable, but only if you anticipate the fall before it happens. So that's an important point to remember. GBS is a treatable condition, but anticipate the respiratory failure before it happens. Hope it was useful to you. Stay tuned for further videos. Thank you.